Hello everyone, my name is Sherry. I'm actually just waking up, but I'm a fourth year medical student going to internal medicine
And where are you right now? I mean,
in Taiwan.
in Taiwan.
Yes, I'm visiting my parents, my family.
Oh, that's why you just woke up.
Yes.
Very,
Right, yeah, it's 8 a.m. there.
very nice. Very nice. So Danielle wants to know what time it is there.
It is 8 at 8 in the morning.
Okay. Drew, you probably need no introduction. Do you need an introduction, Drew?
Other than to say where I've finally gone, have I announced that on
Yes.
the pod? Or okay.
I think so. So one of those Michigan places, they're all
Yeah.
the same.
Yeah. Let's just say Upjohn 2.0.
Upjohn 2.0. Okay,
Yeah.
whatever. Danielle, why don't you tell them about yourself, since you're going to present this case and you're going to help a lot with the discussion.
Yeah, so I'm Danielle. I'm originally from St. Louis, Missouri. I did medical school in Kansas City, Missouri at University of Missouri, Kansas City. But if you're familiar with the program at all, I was not part of the 6-year program. I did the traditional route of undergrad and then medical school. I then came here for residency at the University of Alabama, and then I will be doing pulmonary and critical care next year at University of North Carolina in Chapel Hill.
And Lindsay is our recorder today. I think everybody knows Lindsay, but just say hello, Lindsay, and remind them who you are.
Hi, everyone. I'm Lindsay Shipley, a third-year internal medicine resident at UAB and about to be chief resident in a couple months at UAB, and also member of the clinical problem solvers. So excited to be here. I'll just be scribing tonight.
It's not really a couple months. It's a month and a half.
Yeah.
It's real soon, Lindsay.
I know. I'm not counting down, though. It's just going to happen.
Right. So Danielle, why don't you tell us the story?
All right, so I'm assuming we do this a little bit like morning reports, which is that I have a 65-year-old who comes in with abdominal pain.
Why don't you tell us a little bit more about the abdominal pain?
Okay, so the abdominal pain has been going on for 2 to 3 days. When asked where it's located, he really points all over his stomach. So we considered it generalized abdominal pain. He described it as constant aching pain. And then it was associated with some nausea and small volume emesis.
So Sherry, tell us some of the things you're thinking about right now and what other information you'd like.
So for this patient with abdominal pain, pretty acute, first I want to rule out things that are more life-threatening, like a perforation unlikely, like an obstruction is possible, and any kinds of vascular accident or vascular event like ischemia. I want to make sure it's not happening here. And then based on the location, it's diffuse, so it's really hard to localize. I'm thinking whether this patient is having any signs of inflammations like fevers or chills. Doesn't sound like so. And the differential is quite broad at this point, so it's hard for me to really prioritize my differential at this point, but thinking about doing an exam and see whether there's any signs of fluid overload. And I also want to make sure I don't forget any kinds of extra abdominal organs like the lungs, the kidneys, and or GU or GI, any kinds of other systems. Yeah, that's what I'm at
So-
right now.
If you're going to prioritize the next 2 or 3 questions to ask when you're seeing the patient for the first time, what would be those questions and why? We're really going to get into cognition right now.
So I would like to know whether this patient have any kinds of maybe inflammation or inflammatory symptoms like fevers or chills, or any.
Always a good question.
I also want to know past medical history. So if this patient has cirrhosis, that will completely change my differential.
So you want to know whether or not they've had this abdominal pain before. So Danielle, why don't you help with that, and then we'll let Drew jump in.
Yeah, so he has not had pain like this before. I believe your first question that you wanted to have answered would be, does he have signs of inflammation? And so he denies fevers, chills. It hasn't really been going on long enough for him to have weight loss or something like that either. And then the second question was about past medical history. Do we want to wait on that, or would you like it now, Dr. Centaur?
Let's let Drew ask a few more questions about the abdominal pain.
Okay.
So I think there's been a pretty big surplus of cases of abdominal pain on the clinical problem solvers this past couple of weeks. And one of the things that has been taught by the two R's, Robbie and Reza, has been that abdominal pain is one of those things that on history you can maybe get an idea of what is going on, but you can't necessarily rule out anything. Physical exam, the only things that you can rule out are rash, so herpes zoster, or a hernia. And then on labs, the only things that you can really rule out are pancreatitis if you see an increase, or if you see an increased lipase, or DKA if you see the relevant labs. And as far as I can tell, he doesn't have DKA, euglycemic or otherwise.
No, those are not real labs.
Oh, not
Those
yet.
Sorry about that. Ignore the labs for there.
Those are
just
placeholders.
Yep.
But in general, anyone who has abdominal pain usually goes into the donut of truth, and most likely.
You froze. Drew froze. So we actually have a real expert here today, Dr. Mansour. We're going to put you on the spot, Andre. We're going to have you just tell us your thoughts about how you work up abdominal pain, because I'm interested in hearing what you have to say.
Hey, Bob, thanks for having me. Can you guys hear me?
Yes.
Okay, cool. Yeah, I mean, I think you guys are, on the right path. I mean, I tend to, anytime I'm approaching a problem in general, I try to really have a differential in my mind or a framework, and that helps me. It helps me know what questions or physical findings or labs that I want to know or obtain from the case. And so, and that really allows me to have a hypothesis-driven kind of workup, and it really does start with the history. I'm not going to ask every patient that I see if they have a pet scorpion. You guys were joking about that, but I mean, that's a very specific question that, could come up at times. And so I'm not going to ask everybody that question, but I'm going to ask those who I have a hypothesis, maybe if they have pancreatitis and they're from Trinidad or something like that. So I try to really have a hypothesis-driven workup, and that really makes it more efficient. And it not just about the history, but about the exam and the labs. Because, I really hate, the shotgun approach to labs. I really think it's much more efficient and cost-saving to do a hypothesis-driven workup. So in terms of abdominal pain, there's a couple ways you could, come up with a framework for it. I mean, I think by quadrant, by region, whether it's epigastric, right upper quadrant, left upper quadrant, right lower quadrant, left lower quadrant, or diffuse, I think is helpful. You could do it by organ, hepatobiliary action, intestinal action, and then GU if it's a female patient, especially in terms of the ovaries. So that's kind of how I start. And I start to sort of generate a differential, and then that's really kind of how I approach these things. And so, for example, if I'm thinking hepatobiliary, biliary colic is a pretty common thing. Then I think, okay, well, I'd want to know, what would I want to know about that? How do patients present? When do their symptoms occur, and what does it feel like? And it's really a colicky pain that happens after a fatty meal. So that will lead me to ask them about association with food intake. And then I kind of go from there, and that's sort of how I approach it. If I'm thinking about a vascular cause, I want to know, when I'm examining them, is their pain way out of proportion to my exam? And I go sort of back and forth between my differential and my history taking in my exam in that way.
That's beautiful. And let me just throw out a couple of questions that I almost always ask. Does the pain interfere with sleep? Is there anything that makes it better? Is there anything that makes it worse? I got most of these things from Cope's Early Diagnosis of the Acute Abdomen. I talk about that book all the time, but I think all internists and all surgeons should read that book, at least the first 3 or 4 chapters. It's a very old book from England. They keep updating it, and they've added CT scans and stuff to it. But the basic principle about how to take a history, exactly like Andre just said, is all in that chapter. And how to do the physical exam is all in the next chapter. It's really worth your time to read that. Once you have been doing clinical medicine, it wouldn't help you much before you've done clinical medicine. So Danielle, does this interfere with sleep? Is there anything that relieves, anything that makes it worse?
So he does not report that it's interfering with his sleep, although the pain is constant. He's still able to fall asleep. And then he does not mention any alleviating factors. He hasn't really tried anything at home. He says that the pain began after eating a meal, but beyond that, he cannot correlate it as getting worse with eating meals. It's kind of just constant and aching at this point.
Okay, so let's go ahead and go to the past medical history that was requested.
Okay, so he also has a history of diabetes, although it's very well controlled on just metformin. And then he also has a history of AFib and a DVT. He's on apixaban for those.
On apixaban for DVTs.
Mm-hmm.
Okay. So Xray, does that help us at all?
Sounds like this patient might have some vascular risk factor with AFib that can increase the risk for ischemia, like mesenteric ischemia, although this patient is already on anticoagulation.
Right. Okay. So what about habits?
Like social history?
Yeah, and behavioral history. So
I know you like to separate.
I say this, well, the clinical problem solvers taught me this. Let's say social history is what kind of work they do, who do they live with, where do they live. Behavioral history is sex, drugs, and rock and roll.
Okay. So for behavioral history, he does not smoke. He drinks 2 to 3 beers a week, and he does not use any recreational drugs. Social history, he works as a roofer.
Okay. So right now, Drew, do we have any ideas, or are you ready to examine the patient?
Yeah, I think he had said that the pain started after eating a meal, but any history of him falling off any roofs recently?
No.
Okay.
Good question.
Yeah, because he could have had a trauma to the abdomen, something, maybe toughed off the pain a little bit off of adrenaline, and then it started coming back again. 2 to 3 beers a week doesn't really give me much of a signal for something like a pancreatitis or an alcoholic hepatitis, but weirder things have happened. Travis asked, does he drink Miller or Coors? Honestly, if it's those, if it's that weak of a beer, I don't think it would be that important, would it? And then, yeah, honestly, right now, I think I'd want to examine him.
Right.
I'm trying, yeah, because the thing is that he's saying that the pain is diffuse and generalized, and I'm struggling to figure out if there is a way that we can actually localize this thing. And one of the best ways that we can do it is to do a physical exam, palpate, each of the quadrants and see which one makes him scream.
So one of the points that Andre is making that we should reinforce is that while we do this in a linear fashion at morning reports and in Zoom conferences, in the real world, you're examining and taking the history at the same time, and your physical exam triggers questions. That's the way real doctors work. You can't sit there and take a history for 30 minutes before you ever sit down and examine the patient. You try to get an idea of what's going on and say, okay, it's time. Somebody wanted to know how long he's had diabetes because they were worried about gastroparesis. That's in the differential. It's well controlled just on metformin. Do you know how long he's had it by any chance, Danielle?
Like 3 years.
Okay, that sort of makes gastroparesis a lot less likely. Okay, let's examine him.
Somebody else, just to mention, someone, and Sherry had alluded to this a few times with kind of wanting to rule out ischemia. And then I saw it in the chat box. Someone had asked about melena or hematochezia. So I did just want to comment and say that he says he hasn't had a bowel movement for 3 to 5 days surrounding this. And he denies prior to that any melena or hematochezia. So constipation is going along with his abdominal pain. And somebody else just asked no weight loss.
The small volume emesis, what was the character?
Just nothing specific. Like nothing wasn't.
Nothing. Okay, let's go to the exam. Let's go to the exam because I want to get to the numbers eventually, since this is unremarkable labs.
Yes. So for his vitals, so his temperature is normal. It's 97.8. His blood pressure is 144/106. His heart rate is 97. His respiratory rate is 18, and he's breathing 97% on room air.
So Sherry, you got your signs of inflammation.
All right. So on physical exam, so he looks like he's in just kind of moderate distress, kind of rolling around in bed, trying to get comfortable. I'll just go over the pertinent things at this point in time. He didn't have any JVD. He had normal sclera, no icterus noted there. His lungs at this point in time were clear to auscultation. He was slightly tachycardic when I listened to him, but regular rhythm. And then on abdominal exam, which is obviously what we're all waiting for, he had hypoactive bowel sounds. It was just very distended but compressible. He did not have rebound tenderness, but he was kind of voluntarily guarding on exam. Otherwise, like peripheral extremities, normal gait, no edema, etc.
Okay, so Drew and Sherry, we're going to follow Andre's lead, and I want you to decide what labs you want at this point, and we'll specifically see whether or not we got the labs that you want. So Sherry, you go first. So this part of unremarkable labs is what lab you're going to get and why is that lab important?
Does KUB count as lab?
I'm sorry.
Does KUB count as lab?
No.
No. Oh, maybe lactate.
So you want to lactate. Okay. Is there anything else?
Just the basic, I guess, calcium.
Why do you want a calcium?
Because it can cause constipation and abdominal pain.
Okay. Do you want anything else? Let's see what Drew wants. Drew, what do you want?
I think the big things for me would probably be a lipase or roulette pancreatitis.
Okay.
A basic and probably a. I don't think he had. I'm not sure if he has signs of DKA, but if there's anything off on the BMP, I'd probably want to reflex to a VBG if
Okay, so you do want to be a BMP.
I do want a BMP, and I'd probably see if there's anything off. If there is, then I get a VBG on him.
Okay, and do you want a CBC?
At this point, no. I'm not seeing anything that would make me think that he would have any anything infectious or anemia or anything like that. So this is my peds brain thinking, try not to stick when you don't have to. But although apparently everyone is saying if you are sending labs, get it. What else?
But I mean, he could have a bleed that just hasn't shown up yet.
True. Oh right, yeah, and that could show up as he
could have a strange white count of some kind.
Mm-hmm. He could.
What about liver?
I think in that case, a CMP as well, or upgrade the BMP to a CMP.
You want to make CMP
liver
because you want the liver tests.
Yep.
Okay.
Yeah. And
okay,
then,
Danielle.
Oh, and a UA as well to check for hydration.
Okay.
Okay, so I'll kind of go down the list that you guys have. Oh, no, Lindsay, where are you at? I can start with the.
You can start wherever you like. I'll follow.
So why don't I go ahead and mention the CBC first? Okay, so we have a white blood cell count of 14.9, an H&H of 16.6 and 47, and then a platelet count of 174.
Let's just stop right there because even though Jory May is not here, that's very interesting and actually gives you some information. Sherry, what information does it give you?
We don't have a differential, but it looks like the patient might be inflamed and the H&H is pretty elevated, thinking about maybe the patient is hemoconcentrated.
Exactly, and that actually is useful information. That's useful information. So I think we did get something out of the CBC. Is the differential, do we have anything on the differential, Danielle?
No.
Okay. So I guess we'll, what do you want to do next? The BMP? Because Danielle worked with me. She knows exactly how the order I want things in.
Yeah, so for the BMP, sodium's 141, potassium 3.5, chloride 97, bicarb is 29. His BUN is 16, and his creatinine is 1.5. His baseline is 1, and glucose is 155.
Okay, Drew.
Yeah.
What do you think?
Did we give him fluids yet at this point?
No.
Nope, this is how he walks into the emergency room.
I'd probably start running fluids in him and see how he responds, because his H&H indicates to me that he's hemoconcentrated. His creatinine, that bump probably indicates that he's volume down. So yeah, and his bicarb's a teeny tiny bit elevated. I don't really see any. I honestly don't see anything much other than the fact that he probably has not had a lot of intake. So I'd probably give him fluids first and see how he feels.
And the chat wants to give him lactated ringers. Is that a good idea?
Agreed.
Yeah, you can make a case because his bicarb is a little bit elevated that maybe 1 liter of normal saline, but I would just give him lactated ringers. It's not that high that I'm going to get excited. So what about these other things they wanted? I know we get a calcium with the BMP.
Yeah, so his calcium was 10, and his albumin was normal, so that's what it really was. And then his lactic acid, normal. His LFTs at the time of presentation were also normal. His UA, we actually didn't get one, but if we had, it would have been normal. And then his lipase is 2,484.
That's abnormal at our hospital.
Yes.
Okay. Sherry, what's the most common cause in the United States for pancreatitis?
The alcohol use.
No, it isn't. It's what almost all medical students say. It's still gallbladder disease. It's still the most common cause of pancreatitis. We see more alcohol because the gallstones end up with the surgeons a lot of times, at least on the internal medicine service. So he doesn't have a big alcohol history. Could this be gallstones? Certainly possible. What are other big causes of pancreatitis?
Hypertriglyceridemia is one of the.
Okay. What else?
Scorpion.
There are. Oh, sorry, Sherry, I didn't hear you.
I said scorpion.
Scorpion, yeah.
Scorpion thing.
We didn't get a travel history, but we don't think he either has a pet scorpion or has been to Trinidad. Is that correct, Danielle?
Correct. And I did ask you guys also, we also have to think of things like, has he recently had a procedure? Has he had an ERCP? Anything like that?
Right,
The answer to that is no as well.
Mhm.
Maybe
Yeah,
a little bit more likely than scorpions, but
And Drew asked the trauma question because the trauma is a legitimate reason.
yep, no falls or trauma at all.
Okay, what else? There's some obscure ones that I'll throw at you.
I think autoimmune, some people get autoimmune.
So there's 2 different types of autoimmune. There's IgG4. There's penetrating ulcer. This is really old school, but I think somebody presented me a case of this recently. You can get pancreatitis if you have a gastric ulcer and the pancreas is up against the gastric ulcer. It goes through, instead of having a perforation, it goes straight into the pancreas. You can get pancreatitis. Another reason to get the calcium is because often the calcium is low because of the pancreatitis. And I'm sure we're leaving, medications can do it. A variety of things.
Thiazides are one of the biggest, one of the medications that most people try to point the finger to.
Yeah, but sometimes we're looking for a culprit.
Mm-hmm.
Okay, so what do you want to do now, Drew? No, actually, Sherry wanted an abdominal film, and our emergency medicine expert says you never get an abdominal film.
Would you like to know what the abdominal film would have showed? Are we doing an X-ray here or something else?
So Sherry, have they talked you into a CT scan, or do you want to get a plain film?
Initially, I wanted to get a plain film, but I guess now we can get a CT.
Yeah, I think after you get back that, we're probably going to order CT, and what else might we order? And if you're on my team right now, what would my resident and medical student do at the bedside?
I will also like to look at the Pleural system, maybe with an right upper quadrant ultrasound.
And
And
our third year medical student bought a butterfly handheld ultrasound. So my team is ultrasounding everything this week, which is pretty cool. So CT, ultrasound, we know we're going to get that. Okay.
So we actually did not get an ultrasound this early into his course, given like the normal LFTs and the, like I think someone mentioned, we don't even need imaging technically, given that we can diagnose pancreatitis off of its lipase and his typical symptoms. But of course, he got a CT in the emergency room.
Well, we knew that.
Yeah, hepatic steatosis, and then it showed an edematous pancreas with surrounding fat stranding, and then some gallbladder sludge, but no stones, and a normal sized CBD or common bile duct.
So this is a chance for Lindsay to talk about. We're not having unRemarkable labs next week for personal reasons, very good personal reasons. Lindsay, tell them what we're doing on the 27th.
Yeah, so on the 27th, we're going to have Dr. Bajaj, who is a radiologist at the VA in Birmingham, talk about abdominal CT scans. And I have two really interesting cases for you guys that he will walk through and teach us how to read those.
And we can tell you that'll be at 6 p.m. instead of 7 p.m. to accommodate his young kids' dinner time. Okay, so we got some gallbladder sludge. So, okay, it's pancreatitis. We're going to treat pancreatitis. Big deal. Something must have happened. Otherwise, this is we solved this case. Did we solve this case, Danielle?
Not quite.
Not quite. Oh, what happened?
So I will comment on two different things. So one is his pancreatitis was fairly severe, and he actually developed, if we had gotten that KUB, you would have seen dilated small and large bowel and developed ileus from his pancreatitis. And it took him 5 or 6 days to have improvement in his symptoms.
Could you see the ileus on the CT scan? In
No.
retrospect, you could not.
I don't think he had developed it at that point in time. He had repeated a KUB when he wasn't getting better, and actually eventually about 5 to 7 days in, repeated a CT to assess for any kind of abscess or necrosis, given that he wasn't improving, and that had been negative. But the part that kind of threw us for a loop was that his first night he actually had he had an emergency response call because he was short of breath and what they called hypoxic, and ended up getting put on 2 liters of oxygen overnight. And so the next day we came in and we did a chest X-ray, and he had a left-sided pleural effusion. And so there was some debate about whether we should go ahead and just diurese this gentleman, which based on his initial labs, I think all of you kind of came to the conclusion that that's probably not the right way to go. And yes, it was left-sided. Or tap it. So we tapped it. And would you guys like to know what it showed?
So, Drew, write down, before you talk, write down all the tests you want to get. Sherry, before you talk, write down all the tests you want to get. You're tapping the fluid. I want to know all the tests you want and justify why. This is really good practice for internship. And don't help Drew by putting everything in the chat, because Drew cheats and goes to the chat.
Chat's off then.
Thank you.
Hey, Uncle Bob, while they make their differential, could I tell you my X-ray schema?
Sure.
So I do use abdominal X-rays, mostly in kids, because kids swallow things and you don't want to miss an ingested foreign body in a kid. Adults typically don't, but usually for adults, if they have upper abdominal pain, ultrasound is first. One, because CT scan can miss 50% of gallstones.
Correct.
Huge. Upper abdominal pain is probably one of the majority epigastric pain. So usually the ultrasound is first. But X-rays, like I put before, they're specific. They're not that sensitive. I mean, if you're looking for an SBO and hey, you've kind of, you high suspicion, I think it would help. But it doesn't rule a lot of things out. And I feel like my X-ray techs get really mad when I order abdominal series. They're like, you're just gonna scan them. I'm like, I know. However, I will use it on someone who comes in, multiple ER visits, multiple bouts of abdominal pain. They've had surgeries, and I don't need to scan them again, but they've had surgery before, and I just want to make sure they don't have an obvious obstruction. So that's really the majority of times that I'll use it. Other than that, I'm using ultrasound, and if I'm hedging on it, sometimes a CT scan. But that's kind of my approach to it.
Okay, Sherry, what did you write down?
I think I might be missing something, but I want the LDH protein, maybe amylase or lipase, the pH, the glucose, cell count with diff.
Okay.
Not sure if I want cytology or culture. Maybe culture, but cytology, I'll just get it.
Drew, two heads are better than one. Do you agree with Sherry? Is there anything you would do differently?
Unless Sherry already mentioned lipids, then I think we got everything.
Okay, so I don't think you get lipase on pleural fluid. Do you get lipase or amylase from pleural fluid?
You get amylase.
Yeah, and that's just, you have to know that you get amylase instead of lipase from pleural fluid. And I don't even know why. They did, Victor, they did say LDH and total protein.
Oh yeah, and we also need a serum LDH too.
And a serum total protein.
And serum total protein.
So we can pay homage to Dr. Light.
Mm-hmm.
That's the most important part, is to remember to order your serum studies around the same time.
Yes. So tip for those who are soon to be interns, it's not good enough just to order the pleural fluid labs. You have to order both. So Danielle, reveal, please.
All right, so I will try to kind of go in order. So the pH was 7.4.
Let's, because we haven't talked about pleural effusions before, it's worthwhile to talk about each of these one at a time.
Okay.
So since you're going to be a pulmonologist, why don't you give us the number and tell us what it means and teach our learners.
Okay. And I'll do my best. So for the pH, I was reading a little bit today, and it sounds like a pH somewhere around 7.6 tends to be normal for a pleural effusion. And really, once you're getting below 7.3 is when it's abnormal in general. I think we learn in medical school that, a pH of 7.1, 7.2 is typically indicative of some kind of empyema or infection, usually. But for this patient, I would say that he was within a normal enough range, and I didn't have a suspicion that his pH would be off from some kind of infection, malignancy, etc. And so for him, I kind of considered this normal.
Okay, so that's the first thing. Does everybody agree with that?
Mm-hmm.
Right. Below 7.2, Kushal says gets a chest tube usually. I agree with that.
Mm-hmm. And Danielle, what did the fluid look like when you actually tapped it?
It looked like typical pleural fluid, kind of a yellow straw colored fluid. It was clear, and we got about 600 milliliters off. Okay, So the next thing, so we can kind of do our lights criteria calculation, is that his LDH was 262. And so there are some diseases where, you know, this being high can give you more of an indication for things like TB, et cetera. But in this patient, we're mainly applying it to lights criteria. So we're going to see if the pleural fluid to the serum ratio is greater than 0.6, and or if the pleural fluid LDH is greater than 2/3 the upper limit of normal of our serum LDH.
Anne-Marie just made a very important point. If you're getting the pH, you have to draw it, put it on ice, and send it to the blood gas lab. Is that correct, Anne-Marie?
I believe so. Although I have not sent a pH in a while, but I know that like if it's not sent quickly, that it can affect it. And I think I was once told to put it in a blood gas tube, but I don't know if someone else could confirm that because I'm not sure.
I'm pretty sure you're supposed to put it on ice. But so when you're learning to do thoracenteses as an intern, check twice about that if you're getting a pH, because it's a shame to do the thoracentesis. You take off a bunch of fluid, you send off the labs, and half of them don't get done because you didn't send them out right. So you just have to learn that detail. Thank you very, very much, Anne-Marie, for mentioning that.
And I can guarantee that that did not happen with this patient. So we maybe need to use caution in interpreting the pH. Yeah. The next thing we got was the total protein in the pleural fluid. And for this gentleman, that was 3,000, which would be 3 if you use the same units as his total protein in his serum, which was 6. Right. And so for this, we're using, again, we can apply it to lights criteria and see if it's greater than, the ratio is greater than 0.5.
And his total protein was?
In his serum?
Yes.
6 or 6,000.
Okay. So it was 50%. What about his LDH and his?
His LDH in his serum was 438, which gives you a decimal of 0.59. He's hitting the cutoff for every single one of them, except our normal LDH, where we were seeing this patient, was 225. And so he was greater than 2/3 of normal. So by meeting that one lights criteria, he was classifying as a exudative effusion.
Okay, Vishnu wants to make a point about the limitations of lights criteria. Vishnu, what's your point?
There are some situations where you can have both exudative and transudative pictures in some pathologies. And yeah, and the rest, I don't know. That's why I was hoping you would address them.
Yeah, I think that if you've already diuresed the patient, heart failure can go from transudate to exudate. That's what I seem to remember. Is there anybody else who remembers more about that?
This is Andre. One point about that is that lights criteria is really sensitive for exudates, but it's not as specific. I think it's like 83% specific is the number that I remember. So 17% of true transudates will be classified as exudates just based on that criteria. So and it goes back to the clinical history. So if you're really suspicious of a transudate and it turns out to be an exudate by lights criteria, and you're kind of questioning that, the way to tell is to get a albumin on the fluid. And if you subtract serum albumin, if you subtract that value from serum albumin and it's greater than 1.2, that means it's actually a transudate, and that might be what Vishnu was referring to.
Great,
but it's not very specific. 83%.
The man has spoken. That was great. That was great. So they really do want the amylase.
Yeah, and so in this gentleman, we really had a fairly high suspicion for that. So we did end up. Culture ended up getting ordered, et cetera, some of these other things, but we were really primarily looking for the amylase, and that came out to be 663, which is high for which is high for pleural fluid.
So how do you get amylase in pleural fluid? And then I'll tell you about a case I had a number of years ago that was fascinating.
If the patient vomits too much and has a perforation in the esophagus?
I guess you could from a perforation in the esophagus, but we don't suspect that in this patient. So the question is, how does pancreatitis? The amylase was 663, Lindsay. How does pancreatitis, when you have just pancreatitis, why do you get a pleural effusion? So Danielle's our expert on this because she read up on it.
From my understanding, I think it's from just your surrounding inflammation and your translocation kind of over to the left side of the lung. Is that not what?
It can be. It can be. I actually had a patient a number of years ago who had a right-sided pleural effusion that was pouring out 500 cc's a day with a high amylase in a patient with pancreatic pseudocyst. And we eventually were able to show a fistula from the pseudocyst to the pleura. And so that's another reason you can get it.
Yeah.
And so the question is, if you drain it, does it come back? And the problem we had in our patient, and we eventually had to send the patient to surgery for them to find the fistula and tie it off.
Yeah, that's really interesting. So I would imagine that's from just the amount of inflammation you get in that area, and then it can develop into a fistula. This patient, I almost kind of, unless there was one that we didn't see on his repeat imaging, my suspicion is pretty low for that. It drained and it did not really reaccumulate, and his breathing status improved. And so, and then he had no symptoms like of an esophageal rupture. And I won't get into the weeds of this because it was actually kind of difficult for me to even find today. But if you're really suspicious, there are different like isoenzymes of amylase that you can look into, whether it's pancreatic or salivary, etc. But he had, normally if a patient would have like an esophageal perforation, I would suspect to see some symptoms of that, or reaccumulation, or something associated with eating, which he wasn't doing. So it might make it a little more complicated. But in this patient, I don't think that he had a fistula, unless, like I said, it was small and so small that we didn't see it.
Yeah, if it didn't reaccumulate, I mean, that was what was unusual about the patient that we
really
had.
Interesting.
We were draining 500 cc's per day, and we were having a hard time. We knew he had a pseudocyst, so we assumed he had a fistula, and it was on the right side, which is the wrong side for a pancreatic pleural effusion.
Yeah, that's right. And that was a point that Dr. Hudebert made to us, is there aren't a ton of things that will give you left-sided pleural effusions. And so that's why he specifically wanted us to tap this one to confirm that it was in fact from the pancreas. And after speaking with GI, because like we said, this patient really wasn't getting better, even some of the like prediction tools in pancreatitis use left-sided effusion as one of the clinical points in them.
So let's go ahead and the patient did fine after that. Is that correct?
Yeah, he eventually, like I said, but he didn't have any complications beyond that. And once we drained his pleural effusion, his respiratory status improved. It just took him a while to get over his pancreatitis.
So Sherry, you get to go first. What's the biggest thing you learned from participating? We really appreciate you participating from halfway around the world. You are officially a trooper.
Thank you for this opportunity. It's super fun. Thanks for the case. I think I have a lot of learning cases or learning points, but one thing I learned is the most common cause for pancreatitis is actually gallstone, not alcohol in the United States.
Yeah. Drew.
I think the big thing for me, and I'll probably have to review like the last half of this because the internet kept cutting out, was Light's criteria and the fact that it's sensitive for exudates, but it's not 100% specific. You'll still get some transudates that are misclassified as exudates.
Yeah. And Danielle just put in the chat, they're not 100% sure why he had pancreatitis. Sometimes you just don't find out.
Yeah, we ended up getting a right upper quadrant ultrasound and it did not show any stones and still had a normal sized common bile duct. His lipid, someone just asked, his lipids were normal. He had no interventions. He drinking 2 to 3 beers, you know, we like to say that was it, but I really don't think so. And so his, as far as we can tell, was idiopathic. And I guess we'll see if he has any recurrent cases, but his LFTs did increase, his like alk phos and LFTs increased a little bit during his course of his stay, but we think that was just due to such significant localized inflammation. And we actually went down and talked to your buddies in radiology, and they said it was really severe, pretty much throughout his abdomen, the inflammation that was being caused by the pancreatitis.
He's actually a pretty good age for autoimmune hepatitis, pancreatitis, autoimmune pancreatitis. So we'll have to see if it comes back again.
Yeah.
Lindsay, you're going to be a gastroenterologist one day. What did you get out of scribing on this case and listening to the discussion?
Yeah, really great case. Thanks, Danielle. I think just kind of remembering that, you know, if a patient's not getting better, just go back to the drawing board and start your workout from scratch. And then I love the point about the, even if Light's criteria is suggestive of exudative, but you're suspecting transudate, you can check the serum albumin and the exudate albumin to try to differentiate that. So that was definitely something I learned today.
And I would be remiss if I didn't ask Andre to make a final comment, because we're just so pleased that you joined us today. And I hope you enjoyed this presentation. And what would you recommend we take home from listening to this case?
Bob, this is great. Thanks so much for having me, you guys. I really enjoyed it. Yeah, I mean, I would just reiterate what you guys already highlighted. I think, you know, again, I just like the idea of, I'll just make the point that you made, Bob, during the case, which is when you asked what labs everybody wanted, you said, okay, what lab and tell me why. And I think that's really important when you're thinking about ordering stuff. Think and try to, first of all, try to anticipate, because anticipation is so critical, you know, in medicine. And not only that, but it gives you a reason to order the lab. You know, you're not just ordering it just to order it. You're ordering it because you're looking for something in particular. So that's the point that I would reiterate at the end of the case. But thanks again for having me. I really enjoyed it, you guys.
Anytime. So in 2 weeks, it'll be unremarkable radiology. And we'll all learn that fat stranding is really the radiologist said rate. If you hadn't heard that before, memorize it, and enjoy not signing in next week. Sherry, I hope your trip to Taiwan is most fruitful and filled with delicious food. I'm probably jealous of the food that your mom's probably making you, and should be. Thanks, everyone.
Thank you so much.
Mm.